To start off, I'm talking to you from my operating room. This is a surgery center. It's a fully accredited surgery center, and it's, I don't want to sound strange, but it's all mine. So I'm the only person that works here, and so I have complete say over pretty much everything, which I like because, frankly, particularly this kind of surgery, microsurgery, requires very specific instrumentation, and you got to take care of all of this stuff. Classic to go to a hospital to do a free flap and ask for the micro tray and have the scissors are blunt and the pickups don't pick up and things like that. So here I have complete control and got everything to myself and for myself, which is kind of nice. So a lot of people are really unaware that surgical solutions exist for migraine headaches, and it's true that not all migraine headaches can be remedied with surgery, but quite a few can. And so, one question that we've gotten in the past, Nyla71 asked a couple of days ago for me to discuss, is how do you know whether or not you're a candidate for this type of surgery? And it's a great question, and something that we really cover primarily during our consultation. So really, without a consultation with a headache surgeon, you're not really going to know whether or not you're a candidate. There are a couple of things to look for, though. We see patients who have had previous workups. So if you just have headaches but haven't seen a headache specialist or a neurologist, that's not the time to come and see us. The time is after you've tried to fix your migraines with either medications or alternative therapies, chiropractic, various things that don't involve surgery. And when and if those things don't work, that's the time to come and see a surgeon. Certainly, if something easier than surgery works, that's a better option. But if you're like many people whose other situations don't improve with medications or non-surgical interventions, then you want to see if surgery is an option for you. Now, you want to rule out any other major issues before you see a surgeon, and that usually involves an MRI. And I see a lot of people online, on social media, on Facebook groups in particular, that say, look, my MRI is normal and I'm having these headaches, and treating that like it's a disaster, when in fact, that's a really great situation, because if you have a brain tumor that's causing your migraines, that's not a good thing, right? What you want is to have plain old migraines that don't have a mass effect, shall we call it, or a problem with problematic blood supplies or excessive blood supplies or various types of tumors. Those patients are not going to be candidates for the kind of nerve decompression surgery that we do and have great success with. So you've had a workup, you've tried other things, and you've had an MRI and seen that there's no other problems going on. That's the kind of time to come and see me regarding the surgery. So then how do we actually figure out whether or not you're a candidate? What we're going to do is actually do nerve mapping with injectables. And so we're going to use combinations of short and medium-term anesthetics and treat known nerves that cause migraines. So there are about 14 of these nerves, right? There's 3 occipital nerves. There's the greater occipital and the lesser occipital, which is a little more lateral, and the third occipital, and those commonly contribute to migraine headaches. There's an auriculotemporal nerve over here. There's a zygomaticotemporal nerve over here. There's a supratrochlear nerve here and a supraorbital nerve here. And they're all of these are also obviously on this side, okay? So you're going to come in and you're going to describe your pain. If your pain is starting here and radiating, then we're going to address these nerves. If your pain is starting here, then we're going to address these nerves. If your pain starts back here, we're going to address these nerves. And what you're going to get is a nerve block mapping where I'm going to inject the most likely nerve that's a problem. And at that point, we'll wait about 5 minutes. And if your pain goes away, then you are a great candidate for surgery. If your pain gets better but doesn't go away, then the next key is going to be injecting the next nerve that is the second most likely candidate for your pain, because a lot of patients don't have just one nerve. That's a problem. So by sequentially anesthetizing these nerves, we can tell which nerves are contributing to your pain. And so once we get your pain down from a whatever 7 or 10 or whatnot down to 1 or 2 or 3, well, we know that these are the nerves that are contributing to your pain, and decompressing these nerves is going to be helpful, and that makes you a candidate for surgery. So that's how we decide. You come in and you have a really bad headache, and I do a nerve injection, and the pain doesn't go away, then you're not going to be a candidate for surgery. So hope that helps. Let's see. I had another question from Juliana. Is it nerve excision or decompression? Which is a great question. And the answer is sometimes either one. So what we found out is that these peripheral nerves, when they're irritated, often by constriction, and what can constrict a nerve? Tight muscles, what's called fascia or connective tissue, blood vessels, all of these things. So when these nerves are constricted, they get inflamed. And so that is called a neuralgia. And so we've found that when these nerves are released and no longer constricted, they don't send these pain signals back to the brain, which triggers the entirety of the migraine aura, pain, all of the sequelae that comes with that headache. So if we can, the first thing I'm going to do is find the nerve. I'm going to make an incision wherever it is, in the front, or the side, or the back. And there's on my webpage, my website, headachesurgery.com, you can actually find detailed descriptions of how each surgery is done. We can maybe cover that in another Facebook Live something in the future, but it's a little enough for right now. So we're going to make the incision. I'm going to find the nerve, and I'm going to examine it along its pathway. And while examining it, I'm going to release it through each of the areas that cause constriction. In the front here, sometimes it's actually bone as well as the muscles that cause you to be able to furrow your brow. Back in the back, there are several layers of muscle and fascia, the connective tissue where that nerve passes through in order to get to the subcutaneous tissue, which is where it actually provides feeling for various parts of the scalp. So throughout all of those areas, I'm going to actually release the nerve, again, using microvascular techniques. And we want to see what happens. So if the nerve goes from being kind of angry looking to being a little more healthy, then great. That's a decompression operation, and then that's where we stop. Sometimes, however, these nerves are so damaged from such long time compression and inflammation that the nerve does not look recoverable. And in those cases, we'll actually cut the nerve. So what happens then? While the nerve is cut below the area that has the really bad inflammation, it's important that that nerve then get buried properly in some adjacent muscle, or it will get what's called a neuroma, or independent inflammation of its own. So if we have to, we cut the nerve, bury it in some muscle to prevent the neuroma. And then the area that that nerve innervates, meaning that the area where you have feeling as a result of that nerve going to that area, that will become potentially numb. Now, over time, other nerves tend to make up for things, and so will then restore feeling in various areas. Some nerves, like the greater occipital nerve, have a big area that it innervates, and so we really try not to cut that nerve unless it's looking really bad. Some areas, like the third occipital nerve area, that the area that innervates is really, it's like the size of a silver dollar. And if I cut that nerve, you likely won't even recognize that anything is different, except that the pain starting from the inflammation in that nerve should go away, because that nerve is no longer entrapped and inflamed and giving those pain signals to the brain. So again, sometimes, most often, we're going to actually decompress the nerve. But if the nerve is what's called excessively neuromatous or damaged, then we will often cut the nerve. And either way, the idea is that the pain signals that are going back to the brain that trigger the actual migraine and all that comes with it are no longer happening. And this is where we get the success from the operation. So that's an excellent question. And let's see. Does it help people who have daily chronic migraines? Yes, it does help patients who are appropriate candidates with daily chronic migraine. So if you've got, again, a brain tumor that are causing you to have these daily chronic migraines, then no. But the vast majority of people with daily chronic migraines are having these problems because of neuromatous, inflamed nerves that we make better by decompressing. So this is a really good question, and I'm not even going to get into the entirety of this now. But again, I've got blogs on this on my website, headachesurgery.com. Is it covered by insurance? And frankly, this is not a conversation that any doctor likes to have. The short form of this is that it is usually at least partially covered by insurance. We bill insurance and try to get as much for the patient as possible. But different insurances do different things, fight for different reasons. And I've got a great team of people who fight for the patients to try and get as much money to them as possible. But I can't say with a blanket statement that insurance always or never covers things. We certainly do our best with the constraints that health insurance provides. It's not a great thing for the doctors or the patients, but we do our best. Okay, Jackie asked, how do I do the surgery? So again, this is really covered nicely on our website, headachesurgery.com. But the idea is an incision is made, and then there are certain paths that these nerves commonly take. And we know from extensive literature and extensive research where to find these nerves. And there is variability, so you need to have some experience in how to find the nerve is over here, or it's over here, or it's over here. But in general, they're lying in generally the same area. And so we go down, find the nerve, and then throughout its course, we release the nerve from the from the constricting structures. A lot of times, particularly in the back of the neck, with what's called occipital neuralgia, or migraine headaches that are arising from one of the 6 occipital nerves. It's the muscles around these nerves that are clenching down. And I'll tell you, this is what I have. So I have occipital neuralgia myself, which is one of the reasons I'm so interested in making people better, because it's really, I know what it's like to be down with the migraine. And so along those nerves are these tight muscles, and I actually make a trough of released area along the muscle. So the nerve, rather than kind of being tightly squeezed by the muscle, actually has a channel to go through and relax. And so in this area, again, there's sometimes a little bony tunnel above your eye where these nerves are entrapped. A lot of times it's these muscles up here that are pushing on the nerve, and so we release them, and we also take some fat from one of several different places, depending on what part of the head and neck we're operating on, and put that right next to the nerve to, again, provide some padding so these tighter tissues can't push on the nerve, creating inflammation that triggers the migraine. All right, and then we use obviously some anesthetic, so it's as comfortable as possible. Close things up, put some dressings on, and it's an outpatient surgery. Again, I do it here in my surgery center. Go home you go home that night. I see you the next day. Many of our patients are traveling, so we have hotels that we arrange for you. I got one of my patients staying at a local hotel that I operated on last week. I saw her the day after surgery. She had no pain, which was great, but I like for people to stick around for a week so I can be around to answer questions, have some follow-up. I see them a week later, and when there's nothing wrong and all of the patient's questions are answered, then you're released to go home. And if home is, states away or overseas, I prefer to be able to see people on a long-term basis, but realistically, that's not possible. For patients who are local, particularly in the Los Angeles area, then I will see them a couple weeks later and a couple weeks after that, again, to check in, mostly just to make sure that there's no questions that they have, or just to make sure that they're continuing to do well. So I want to make sure that that everybody is comfortable, both without pain and and with any questions that they might have. Otherwise, of course, we're available on the phone, and you can call to ask questions at any time. So that is how the surgery is done. So this morning I got a question from a woman whose daughter had an accident, and she wants to know if the likelihood that her daughter was a candidate. So a couple of things about that. Number one, teenagers have migraines. Kids have migraines, okay? And age, I'm not going to operate on a baby or a young child, but we operate on teenagers for this problem. And frankly, I've had migraines since I was in my teens, and I know what that's like. So, so that's one thing. The second thing is that trauma is a very frequent cause of these types of problems. Whiplash or falls. This particular case, this young lady had fallen in. She was a cheerleader, I guess, and fell. And so car accidents and situations where your head gets jerked around, that often causes long-term tightness of the muscles and connective tissue in the neck. And many of our patients have a history of some kind of whiplash or trauma in the past. Some of them come in without thinking about this, and I asked them if they've ever gotten in a car accident, and this happened last week, and somebody said, "Oh, you know what? I thought it was that I got these around my pregnancy, but as it turns out, I remember I did get rear-ended when I was pregnant, and it was around then that I got the headache." So again, very common that a history of trauma in the background has caused these tissues to become tight. It's not exclusively that, and many people have what's called idiopathic migraines. And idiopathic is a medical word for we don't know why. You can't find anything on the MRI. We can't get anything in the history that would cause a problem. And these idiopathic migraines, probably actually the most common, and yet the most frustrating, because I've talked to countless people who say that, well, I go to my doctor and I'm asking for pain medications and they think I'm just drug seeking. Well, there's nothing on a report or a study or a spot on your body that says, oh, you're having migraines because of this, that, or the other. There's nothing to be found, and yet you're in pain. And so because a lot of doctors don't have that understanding of, hey, just because I can't find something solid on a study or on a physical exam, that doesn't mean that this person is not in tremendous debilitating pain. So, so these idiopathic situations or migraines where we can't actually find a reason, we're now discovering that a lot of these patients have these inflammatory issues of these peripheral nerves. And maybe it's just because the muscle in that area is big. Maybe it's just because there's an artery. For example, the occipital artery, which is a small artery in the back of your head, that frequently goes right across the greater occipital nerve. And in a lot of people, it's not a big deal. It doesn't bother them. But in some people, that pulsation of that artery is causing chronic inflammation of that nerve, and they're getting these pulsing headaches, and nobody can figure out why. Well, those people who've had decompression surgery get great outcomes because we see that artery. That artery happens to be not extraordinarily important. We divide that artery, release the tissue, release the nerves, and relieve the pain. So these patients who are the most frustrated with a lack of a cause and a lack of a understanding of why they're having the pain, those are often the most the patients who are going to most benefit from nerve decompression migraine surgery. And so it's actually getting to those people to get them to understand that I can help, or one of my peers, of whom there are more and more. It's not something that you can find a migraine surgeon on every corner, but we're trying to spread these techniques to others so we can help as many people as possible. But these people are often the most helped and the best candidates for surgery. So let's see. I've got a couple of familiar faces here that have joined us. See if there's any other questions that that we can help with. We're kind of running towards the end of where we're going. Do I have to see a neurologist? So again, before you're seeing a migraine surgery specialist, you do need to see a neurologist, get a complete workup, make sure that there's nothing significant going on that is aside from compressed nerves, because we don't want to be doing a nerve decompression surgery on somebody who has another reason to be having a headache. We're not going to be able to fix, for example, a Chiari malformation or one of these more esoteric issues that are in the brain. So, and this is not brain surgery, okay? I and most of my peers are actually plastic surgeons. And the reason that plastic surgeons do migraine surgery is because we are the most familiar with microvascular surgery, which again, if you're not in our world, can be confusing. You would think a vascular surgeon would do microvascular surgery, but we are trained in microvascular surgery when we are moving tissue from one part of the body to another to do reconstruction. And again, maybe I can cover this at another time, but plastic surgeons are specifically trained in microvascular surgery, and it's microvascular techniques that we use to manipulate peripheral nerves. And it's the peripheral nerves that are being compressed and sending messages back to the brain that bring on the migraine headaches. And so what we're doing is decompressing the nerves so we can prevent those problematic signals from going back to the brain and triggering the migraine in the first place. So again, hope that's been helpful. I'm on Facebook, clearly, if you're here, you know that. But you can always ask questions. Please do understand that social media is not a great means to communicate about specific cases. So I'm not going to be able to say, your situation is X, Y, or Z on Facebook or Facebook Messenger, but contacting my office, 805-969-9004. We can set up a Skype or a phone consultation to start things off to see if we can answer some questions. But if you have general questions, I'm more than happy, and frankly, I appreciate them because everybody has the same questions. So if I can answer your question, please understand, again, there's no bad questions. Most people are going to benefit from that answer. And so send me some questions. I'll answer them on our Facebook forum if they're not specific to a particular patient. And we'll also keep them for future things, for future Facebook Live events. If I come, okay. So Molly's asking if she comes from 1,000 miles away, and she's a candidate, can we do the surgery? So the way we do these kinds of things is we do a Skype consultation, and I make sure that there's no obvious reasons that the patient is not a candidate. So I want to make sure that in general, it sounds like I can help. And if that's the case, we have you come, we do a consultation, we do the nerve mapping, which I referred to earlier in the video, as well as you can find information about this as well on the website and the blogs on headachesurgery.com. But we do the nerve mapping to see, or basically prove that you are a candidate. And if you are a candidate, we will have already set up a few days later to have the surgery done. So people coming from very far away, answer is yes. We do a Skype consultation, then we see you then a few days later, we actually do the surgery that's scheduled. And again, I like you to be in town for a week after the surgery itself. And again, talked about that a couple of minutes ago. So it's a good question. All right, by the clock on the wall back there, it looks like we are about through the time I have. So hope it's been helpful. And we are trying to spread the word that we can help. A lot of patients are feeling helpless, and this is a great opportunity to find relief. And I love doing it. So I'm happy to talk. All right, take care. And I got to find the right button on here. I think that's it.